Okay, imagine this. Your shift's just starting. Busy med-surg floor.
Yep, been there.
In one room, you've got a young adult just diagnosed with type 1 diabetes. They're grappling with this huge life change, right? And the immediate need for insulin, daily injections.
Overwhelming for them.
Totally.
Yeah.
Then, down the hall, maybe an older adult, type 2, managing not just blood sugar, but, the complications, neuropathy maybe, tingling feet.
Or kidney issues starting.
Exactly. And somewhere else, another patient, maybe their sugars are all over the place, or they have a cold that's throwing everything off, or a family just desperate for answers about sick days.
It's constant. Diabetes management touches so many patients.
It really does. And that's exactly what we're diving into today, diabetes. But this isn't just about memorizing facts for a test, although, yeah, understanding this stuff, absolutely going to help you on the NCLEX.
You're sure.
This deep dive is about really getting the nuances, the disease itself, how we diagnose it, and the comprehensive care that nurses provide. We want to give you, our future nurse listener, that solid foundation, make you feel confident.
That's exactly right. Our mission here is to, break down the essential knowledge.
Yeah.
Stuff straight from your core learning materials.
Yeah.
We're pulling out the really vital insights, trying to present them in a way that, clicks.
Yeah.
So you move past just remembering facts to truly understanding.
Right.
We want to equip you with a really robust foundation, something that serves you well on exams, yes, but maybe even more importantly, in your actual clinical practice, day in, day out.
Makes sense.
Because mastering these concepts means you can spot issues faster, intervene effectively, educate your patients with real clarity and compassion. You can make a difference right away.
So what's the plan for today? Our roadmap for this pretty extensive deep dive.
Lay it out.
Okay. We're starting with the basics. The fundamental differences between type 1 and type 2. Really getting that core pathophysiology down.
Crucial starting point.
Then we'll move into meds, medication management, recognizing those critical lab values, understanding how to spot and, crucially, respond to emergencies like DKA.
Diabetic ketoacidosis,
Yeah.
Can't miss that.
Definitely not. But we're not stopping there. We'll also spend good time on patient education, holistic care, things like meticulous foot care, how to handle exercise safely, navigating those really tricky sick days, and understanding blood sugar extremes, both high and low. Our goal is to make all this complex info digestible, relevant, and immediately useful for your nursing career.
Sounds like a plan. Let's make this complex stuff clear.
Let's do it.
Okay, let's start right at the foundation, like you said, differentiating type 1 and type 2 diabetes.
Yeah, why is that distinction so critical right off the bat?
Well, it's absolutely paramount because it shapes pretty much everything else. The patient's care plan, the education they need, their long-term prognosis. It all stems from understanding which type they have. Getting the underlying mechanism is step one for effective nursing.
Okay, so type 1 diabetes first. Let's zoom in. When we talk type 1, what's the fundamental why? What's actually happening inside the body?
Right. So type 1, what's really key to understand, and it's often tough for patients and families to hear, is that it's fundamentally an autoimmune disease.
Autoimmune. Okay.
Yeah. Think of it like this. Your immune system, which is supposed to protect you, right, from bacteria, viruses, it makes a mistake. It turns on the body itself. In type 1, it specifically targets and destroys the insulin-producing beta cells in the pancreas.
So the body attacks its own insulin factories, basically.
Exactly. These beta cells, they're the only cells that make insulin, that critical hormone that lets glucose get into our cells for energy.
So the defense system becomes the problem.
Wow. And what's the direct result of that attack when those beta cells are gone?
The direct consequence is a complete lack of insulin production. Absolute. The pancreas just stops making it because the factories, the beta cells, are destroyed.
Okay, complete lack. That sounds like a major difference from type 2. It is. It's the crucial distinction. Without any insulin, glucose gets trapped in the blood. It can't get into the cells, so the cells are starving for energy, even though there's tons of sugar floating around.
Like having a key, but it doesn't fit the lock anymore, or no key at all.
More like no key at all. The insulin key is just gone.
Got it. So as a nurse, knowing this autoimmune, complete lack of insulin, how does that change how you talk to a newly diagnosed patient or their family?
It's huge. Understanding this absolute lack of insulin explains why type 1 often shows up so suddenly, sometimes really dramatically, with symptoms getting bad fast.
Right.
And it means, unfortunately, that they'll need lifelong insulin therapy right from diagnosis.
No other option, really.
Nope. And knowing it's autoimmune, That's vital when you're explaining. You can say with empathy, look, this wasn't caused by anything you ate or your lifestyle, not in the same way type 2 can be linked to those things.
That must relieve some guilt for people.
It really can, especially for parents of kids diagnosed with type 1. It helps them understand insulin isn't just another medicine. It's replacing a vital hormone their body just can't make anymore. That shapes your whole education approach, the support you give. It's critical.
Yeah, that emotional support piece is huge. Okay, let's pivot then. Let's talk type 2 diabetes. How does its why differ from type 1?
Right, so type 2 is fundamentally different. It's usually characterized by one of two things happening, or often a mix of both.
Okay.
First, the body's cells don't use insulin properly. They become resistant to it. We call that insulin
The
resistance.
sticky lock analogy you mentioned. Right?
Exactly like the sticky lock. The insulin key is there, but the cell door lock is jammed. It doesn't open easily to let the glucose in.
So the insulin's there, but it's not working right.
Mm-hmm.
What's the second scenario?
The second piece, especially as the disease progresses, is that the pancreas might just not make enough insulin to keep up with the body's needs, especially with that resistance going on. So, key difference. The pancreas does produce insulin in type 2, at least at first, but either the cells ignore it or the pancreas just can't pump out enough to overcome the resistance.
Got it. Resistance or not enough production or both. Are there certain groups or risk factors that, as nurses, we really need to keep an eye on for type 2?
Definitely. When we look at risk factors, it's really important to know that some populations are disproportionately affected. For instance, African Americans, Hispanic Latinx individuals, American Indians, Asian Americans, they all have a higher prevalence of type 2.
And why is knowing that so important for a nursing student, for their practice?
Because it guides your actions. It tells you who might need more targeted screening. It helps you provide culturally competent care, respecting different beliefs or practices around health and food, and it helps tailor prevention efforts. You need to be proactive in assessing and educating these groups.
Makes sense. And type 2, it often doesn't travel alone, right? It seems linked to other conditions. Tell us about metabolic syndrome.
Yes, that's a really crucial connection. Metabolic syndrome significantly bumps up the risk for type 2 diabetes and also heart disease. Recognizing its components is like having an early warning system.
Okay, so what are the components? What makes up metabolic syndrome?
There are 5 key factors, and a patient is diagnosed if they have at least 3 out of these 5.
3 out of 5. Got it. What's the first one?
First is abdominal obesity. And this isn't just general overweight. It's specifically that fat stored around the waistline. Central adiposity, like an apple shape.
Belly fat.
Exactly. That visceral fat is really metabolically active. It drives insulin resistance and inflammation. We look at waist circumference, greater than 40 inches for men, greater than 35 inches for women. That's a red flag.
Okay, so waist size matters more than just BMI sometimes. What's number 2?
Number 2 is hyperglycemia, basically elevated blood sugar. Might be a fasting glucose of 100 milli-GDL or more, or maybe they're already on meds for high sugar.
Right. And number 3?
Third is hypertension, high blood pressure, specifically 130 over 85 millibhg or higher, or again, being on medication for it.
Okay, abdominal obesity, high sugar, high blood pressure. What's 4?
Fourth is hyperlipidemia, high levels of fats or lipids in the blood. For metabolic syndrome, we specifically look at high triglycerides. Think of triglycerides as stored fat.
Okay.
High levels often mean the body's storing too much fat from the diet, a sign of metabolic issues. The threshold here is triglycerides equal to or greater than 150 milli-GDL.
150 or higher for triglycerides. That's a clear marker. And there's a 5th component related to lipids too, right? The HDL.
Yes, the 5th component involves HDL cholesterol, the good cholesterol.
Right, you want that one high.
Exactly. HDL helps clear out excess cholesterol. So low HDL is a problem. It increases cardiovascular risk. Specifically for metabolic syndrome, it's an HDL less than 40 milli-GDL for men and less than 50 milli-GDL for women. So you want it higher than those numbers.
Okay, less than 40 for men, less than 50 for women is bad. Got it. So if you see a patient with that belly fat, high sugar, high BP, high triglycerides, and low HDL, that's metabolic syndrome.
If they have 3 or more of those 5, yes.
So why is recognizing this cluster so powerful for nurses? What does it let you do?
It's incredibly empowering because you can identify people at really high risk for type 2 diabetes and heart disease, often before they get the full diagnosis.
It's about prevention.
Exactly. It opens the door for early, potentially life-changing interventions. You can facilitate lifestyle modifications, diet changes, more activity, weight management. You educate them on prevention. You could help slow down or maybe even stop the progression to full-blown type 2 and all its complications.
Like heart attack, strokes, kidney failure.
All of it. It's proactive care, empowering patients to change their trajectory.
That really highlights the nurse's role in prevention. Okay, so we've got the foundations, the types, the risks. Now let's talk about what you actually see, the clinical picture. What are those classic signs and symptoms that should make a nurse think diabetes?
Right, the clinical presentation.
Mm-hmm.
When we talk about uncontrolled diabetes, especially hyperglycemia, the first thing that comes to mind are the 3 Ps.
The classic 3 Ps. Okay, let's break them down. Polyuria first. What's happening there?
Polyuria just means excessive urination. What happens is when blood glucose gets really high, the kidneys get overwhelmed. They can't reabsorb all that extra sugar.
Too much sugar for them to handle.
Exactly. So the body tries to flush it out in the urine. But glucose acts like an osmotic diuretic. It pulls a lot of water with it.
Ah, so the sugar pulls water out?
Loads of it. Leads to a huge increase in urine output. Patients might complain about going to the bathroom constantly, day and night.
Okay, so the body's trying to dump sugar, loses lots of water, which leads directly to the next P, polydipsia.
You got it. Polydipsia is excessive thirst. It's a direct result of that massive fluid loss from polyuria. The body gets dehydrated, cells start to shrink a bit, and the brain's thirst center kicks into high gear. It's screaming for more fluid to replace what's lost. Patients feel incredibly thirsty, like they can't drink enough.
Makes sense. Constant peeing, constant thirst. Now the third P, polyphagia, this one's a bit counterintuitive. Why excessive hunger when there's so much sugar in the blood?
Yeah, this one highlights the core problem. Polyphagia, or excessive hunger, happens because the body's cells are actually starving for glucose.
Even with high blood sugar.
Exactly. Even if the blood sugar is sky high, without enough working insulin, that glucose can't get inside the cells to be used for energy.
So the fuel's there, but it can't get into the engine.
Perfect analogy. The cells are starving, so they send signals to the brain saying, we need more food, more fuel. Even though the problem isn't lack of fuel in the blood, it's getting it into the cells.
That makes so much sense now. Cellular starvation drives the hunger. Are there other key signs nurses should look for, especially when trying to figure out if it's type 1 or type 2 or a new diagnosis?
Yes. One really critical sign, especially common in uncontrolled type 1, is unexplained weight loss.
Weight loss, despite the polyphagia.
Right. Because the cells can't use glucose, the body starts breaking down fat and muscle for energy instead. So even though they're eating more, they lose weight, sometimes rapidly. This is a big contrast to type 2, where weight gain or obesity is often part of the picture.
Okay, so 3 Ps plus weight loss really points towards type 1. Any others?
You might also see fatigue, profound fatigue because the cells aren't getting energy. Blurred vision because high sugar can affect the lens of the eye. And slow wound healing, especially more common in type 2, due to poor circulation and high sugar levels impairing immune function.
Got it. So when you suspect diabetes, how do you prioritize assessing for these? What does finding them tell you?
Assessing for the 3 Ps is fundamental. You ask about the degree of thirst or urination, how long it's been happening, if it's disrupting their life, is it new?
Yeah.
And you need to differentiate. Could the thirst be simple dehydration? Probably not if they also have polyuria and maybe polyphagia or weight loss. Finding this cluster strongly points towards diabetes and tells you, okay, we need to check blood sugar, notify the provider, investigate further. It guides your immediate next steps.
Makes sense. Okay, speaking of next steps and serious issues, let's talk about a major acute complication. Diabetic ketoacidosis, DKA. When should alarm bells be ringing for a nurse?
DKA is a true medical emergency, life-threatening. It's most common in type 1 but can happen in type 2 during severe stress or illness.
Okay.
You suspect DKA when a patient has really severe hyperglycemia sugars, often way up there, 300s, 400s, 500s, even higher, plus significant dehydration. And often symptoms like bad abdominal pain, nausea, vomiting, extreme fatigue. It comes on relatively quickly.
Wow, okay. Sky-high sugar, dehydration, feeling really sick. What's the definitive clue, the key finding that screams DKA?
The absolute crucial diagnostic marker is finding ketones in the urine or blood.
Ketones, why are they there?
Because the body has virtually no insulin working. It can't use glucose. So it desperately starts breaking down fat for energy at a very high rate. This rapid fat breakdown produces acidic byproducts called ketones. They build up in the blood, making it acidic. That's the acidosis part of DKA. metabolic
And then
acidosis.
isn't there often a distinct smell associated with that?
Yes, often a fruity odor on the breath. It's acetone, one of the ketones, being exhaled.
Mm.
That's a strong sign.
Fruity breath.
Yep.
Okay. And what about their breathing? Is there a characteristic pattern?
Absolutely. You'll very likely see Kussmaul respirations.
Kussmaul. What does that look like?
It's deep, rapid, kind of labored breathing. It looks frantic. It's the body's attempt to compensate for the metabolic acidosis. By breathing fast and deep, they're trying to blow off excess carbon dioxide, which is acidic in the blood, to try and raise the blood pH back towards normal.
So the body's trying to fix the acid problem with breathing.
Okay. Recognizing these signs then, ketones, Kussmaul breathing, what's the immediate nursing priority?
Immediate and aggressive intervention. This is not a wait and see. It's critical. Your priorities are: alert the provider immediately, start large volumes of 5e fluids right away to combat the severe dehydration.
Fluids first.
Fluids first, definitely. Then administer insulin, usually regular insulin, via an IV infusion, not subcutaneous initially, and very careful monitoring and replacement of electrolytes, especially potassium. Potassium levels can swing wildly and dangerously during DKA treatment.
Wow, okay. Fluids, free insulin, watching potassium like a hawk. It sounds like rapid, precise nursing is literally life-saving here.
It absolutely is. Your quick assessment and actions are critical. Okay, so that's the emergency. Now let's talk diagnosis and monitoring. Labs are key. What about fasting blood glucose, FBG? What numbers do nurses need to know?
FBG is a standard test. After fasting, usually 8 hours, an FBG of 100 milli-GDL or higher is considered elevated.
Yeah.
Getting into prediabetes range.
Okay.
An FBG of 126 milli-GDL or higher on 2 separate occasions is diagnostic for diabetes.
126 or more on 2 tests. Got it. What about the other end, hypoglycemia? What's the FBG danger zone?
Yeah, hypoglycemia is generally defined as an FBG of 70 milli-GDL or less, but 60 milli-GDL or less is often considered critically low and requires immediate action. That signals not enough glucose for the brain.
Okay, 70 or less is low, 60 or less is critical. How do nurses use these FBG results day to day?
You use them to guide immediate actions, give glucose if it's low, assess further, and talk to the provider if it's high, and also for patient education, helping them understand their self-monitoring results.
So FBG is a snapshot, but for the long-term picture, we use hemoglobin A1C, right? What's the diagnostic cutoff there?
Right. For A1C, the diagnostic value is 6.5% or greater. That confirms diabetes.
6.5% or higher. And why is A1C so valuable? What does it tell you that a single FBG can't?
A1C is incredibly important because it gives you an average blood glucose level over the past 2 to 3 months.
2 to 3 months. How does it do that?
Glucose in the blood naturally sticks to hemoglobin in red blood cells, and red blood cells live for about 120 days. So the A1C measures how much glucose has attached over the lifespan of those cells.
So it's not affected by what you ate just yesterday.
Exactly. A single FBG can jump around based on meals, stress, whatever. A1C gives you a much broader, more stable picture of overall glycemic control over time. It shows the trend.
That makes sense. So how do nurses use A1C in practice?
We use it to monitor how well the overall treatment plan is working. Is it effective long-term? We use it to educate patients on their progress, or maybe identify, hey, things aren't well controlled, we might need to adjust meds or lifestyle. It's key for tracking progress towards goals.
Got it. A1C for the long view. Okay, we've covered types, symptoms, emergencies, diagnosis. Let's move into the meds, the pharmacological arsenal. What's the first line go-to drug for type 2 diabetes?
For type 2, the medication you'll see prescribed first, most often, the real cornerstone for many, is metformin.
Metformin, okay, heard of it.
Yeah, it's especially good for patients who are overweight or have significant insulin resistance.
And metformin comes with a super critical nursing consideration, right? Especially around imaging.
Yes, this is a huge patient safety point, non-negotiable. You must hold metformin for 48 hours before and 48 hours after any procedure involving IV contrast dye, like a CT scan with contrast.
Hold for 48 hours before and after. Why? What's the risk?
The risk is a serious complication called lactic acidosis. Metformin is cleared by the kidneys. IV contrast dye can sometimes temporarily impair kidney function, especially if there's already some underlying issue or dehydration.
Yeah.
If the kidneys aren't clearing metformin properly because they're stressed by the dye, the drug can build up. This buildup can cause lactic acid levels to rise dangerously high.
Lactic acidosis, what does that look like?
It's bad. Severe weakness, muscle pain, trouble breathing. It can progress rapidly to organ failure, even death. So, holding the metformin prevents this buildup if the kidneys get temporarily hit by the contrast. Your vigilance here, checking meds, checking kidney function, educating the patient is a direct safety measure.
Wow. That really drives home how crucial that specific instruction is. Okay, metformin hill for contrast. Now let's talk insulin therapy. Used in type 1 always, and often in advanced type 2, let's start with rapid-acting insulin, like Lispro or Aspart. What's key about its timing?
Rapid-acting insulin, like Lispro, Humalog, or Aspart Novolog, kicks in super fast, usually within 15 to 30 minutes.
15 to 30 minutes, that's quick.
Very quick. And its peak effect isn't far behind, maybe 30 to 90 minutes. So the absolute crucial nursing implication, something you'll live by, is food in front of the insulin, meaning you must make sure the patient eats very soon after getting the injection. If they don't, their blood sugar could plummet dangerously low because the insulin starts working before the food glucose gets absorbed. High risk of severe hypoglycemia.
Got it. Food right away for rapid-acting. Now, what about long-acting insulin, like Glargine, Lantus, or Datamir, Levemir? Is there a special rule about mixing these?
Yes, another absolute rule. Glargine or Datamir should never, ever be mixed with any other type of insulin in the same syringe.
Never mix the long-acting ones. Why not? What happens?
Because mixing them messes up how they work. Glargine, for example, is designed to form little microprecipitates under the skin, releasing slowly and steadily over 24 hours with no real peak.
Okay.
If you mix it with another insulin, it destabilizes that formulation. Its action becomes unpredictable. You might get unexpected peaks, risking lows, or it might not last as long, risking highs. It defeats the whole purpose of having a steady, long-acting background insulin.
Right, so keep Glargine and Datamir separate. Clear. But you can mix some insulins, right, like regular and NPH?
Yes, you can mix regular and NPH. And there's a very specific way to do it using the mnemonic clear before cloudy. Or sometimes people remember RN, regular before NPH.
Clear before cloudy, so drop the regular first.
Exactly. Regular insulin is clear. NPH insulin is cloudy because it has additives. You drop the clear, regular insulin into the syringe first, then you drop the cloudy NPH insulin into the same syringe.
Why that specific order?
It prevents the cloudy NPH from accidentally getting into the clear, regular insulin vial. If that happened, the additives from the NPH could contaminate the regular insulin and potentially change how quickly it works. Following clear before cloudy ensures accurate dosing and predictable action from both when they're mixed.
Makes sense. Preserve the integrity of the clear insulin.
Okay, beyond mixing, what about just administering insulin? What's crucial about where you inject it?
Site rotation. This is vitally important and a key piece of patient education. Patients need to consistently rotate their injection sites.
Where can they inject? Common areas are the abdomen, but staying about 2 inches away from the belly button, the outer thighs, the back of the upper arms, and the buttocks.
And why is rotating so crucial? What happens if they keep using the same spot?
If they keep injecting in the same small area, they can develop lipodystrophy. This can look like fatty lumps under the skin, or sometimes indentations, basically scar tissue forms.
And that scar tissue messes things up.
Big time. Insulin absorption from scarred or hardened tissue is really unpredictable. Sometimes it absorbs too slowly, sometimes too quickly, sometimes hardly at all. It leads to erratic blood sugars, making control incredibly difficult, even if they're taking the right dose.
So rotate sites to ensure consistent absorption. Got it. And what about rubbing the site after injection? Good idea or bad idea?
Generally, not recommended. Massaging the site can actually speed up insulin absorption unpredictably. Might cause a faster drop in blood sugar than expected, risking hypoglycemia. Just gentle pressure, if needed for bleeding, is usually sufficient.
Okay, no rubbing. Rotate sites. Now, let's talk sliding scales. They're common. But what if the patient's sliding scale dose just isn't cutting it? Their sugar stays high despite the doses ordered. What's the nurse's best move?
Right. If the sliding scale, which is a standing order based on current blood sugar, isn't effectively bringing the glucose down consistently, the best and most appropriate nursing action is to call the physician for new orders.
You can't just give a bit more based on the scale.
No, not typically.
Yeah.
The sliding scale has set parameters. If those parameters aren't working, it signals something has changed with the patient. Maybe they have an infection brewing, maybe their insulin resistance has worsened, maybe their diet changed.
Ah, the underlying situation requires reassessment.
Exactly. It's beyond the scope of the standing order. The physician needs to reassess the patient and potentially adjust the basal insulin, the correction factor, or look for other causes. Your role is to recognize the pattern, see the scale isn't working, and escalate appropriately. It shows critical thinking and understanding scope of practice.
That's a really important point about nursing judgment. Okay, last medication point. Glucagon. We mentioned it for emergencies. What exactly is it again, and what's its nickname?
Glucagon is a hormone, also available as a medication. It does the opposite of insulin. It rapidly raises blood glucose. It tells the liver to dump its stored glucose, glycogen, into the bloodstream.
Fast glucose boost.
Yep. Its common nickname is brain candy because it quickly gets sugar back up to the brain during severe lows. It's used for emergency treatment of severe hypoglycemia, especially if the person's unconscious or can't swallow.
Brain candy for severe lows. Good way to remember it. Okay, that leads us perfectly into managing blood sugar extremes. Let's start with the lows. Hypoglycemia. What are those classic signs nurses need to recognize immediately?
Hypoglycemia symptoms generally fall into two groups:
Mhm.
autonomic, which is the body's adrenaline response, and neuroglycopenic, which is the brain not getting enough sugar.
Okay.
The autonomic ones are often called the shakes and sweats. Think tremors, feeling anxious or nervous, sweating, often cold, clammy sweat palpitations, maybe intense hunger.
Adrenaline kicking in. And the brain symptoms.
The neuroglycopenic ones, the impaired brain signs, include blurred vision, dizziness, headache, irritability, confusion, difficulty concentrating, maybe slurred speech. In severe cases, it can lead to seizures or loss of consciousness. Important note: bradycardia, slow heart rate, is not typical. Usually the heart rate is normal or slightly fast.
Got it. Shakes, sweats, confusion, blurred vision. Now, if a patient has these mild to moderate signs, but they're awake and can swallow, what's the go-to intervention? The rule.
For someone awake and alert with mild-moderate symptoms, you use the rule of 15.
Rule of 15. How does that work?
You give them 15 grams of a simple, fast-acting carbohydrate. Good examples are 4 ounces, half a cup of fruit juice, or regular soda, not diet, 3-4 glucose tablets, or maybe a tablespoon of honey or sugar.
Simple carbs for a quick boost. Then what?
Then you wait 15 minutes and recheck their blood sugar. If it's still low, usually below 70 mg/dL, you repeat the 15 grams of carbs.
Repeat the process.
Yep. Repeat the 15 grams, wait 15 minutes, recheck. Keep going until the blood sugar is back in a safe range. Once it's stable, it's often good to give them a small snack with complex carbs and protein to prevent it from dropping again.
Okay. Rule of 15 for conscious lows. What if they're unconscious? Or having a seizure? Can't give them juice then.
Absolutely not. If the patient is unconscious or unable to safely swallow due to severe hypoglycemia, the priority action is administering glucagon IM intramuscularly.
Injectable glucagon.
Right. Trying to force fluids or food into an unconscious person is a huge aspiration risk. Glucagon injection stimulates the liver to release glucose systemically. If they have IV access already, administering 5-ED50, 50% dextrose, is another option, often faster. Once they regain consciousness, you follow up with oral carbs.
Critical difference based on consciousness. Glucagon or 5-E dextrose if unconscious. Now, when teaching patients, distinguishing simple versus complex carbs is important too, right? Not just for lows.
Definitely. Patients need to understand the difference for daily management. Simple carbs, like juice, candy, regular soda, those are for treating hypoglycemia because they digest fast and raise blood sugar quickly. A quick fix.
Okay.
Complex carbs, on the other hand, like whole wheat bread, oatmeal, brown rice, starchy vegetables, beans, they digest more slowly. They provide more sustained energy release and don't cause those rapid spikes and crashes in blood sugar. These are the foundation of healthy meals for diabetes management, not for treating acute lows.
Simple for the quick fix, complex for sustained energy. Got it. Now let's tackle those confusing early morning high blood sugars. There are two culprits, right? Dawn phenomenon and Somogyi effect. They look similar but need opposite treatment. Let's start with dawn phenomenon. What's causing that?
The dawn phenomenon is caused by the body's natural overnight release of counter-regulatory hormones. Think growth hormone, cortisol.
Yeah.
These naturally start to rise in the early morning hours, usually between like 2 a.m. and 8 a.m.
Preparing the body to wake up.
Exactly. These hormones tell the liver to produce more glucose. In someone without diabetes, their pancreas just releases a bit more insulin to handle it. But in someone with diabetes, especially type 1, they don't have that response. So blood sugar drifts up in the early morning.
So it's a natural hormonal surge causing the high. How do you manage that? What's the typical adjustment?
To counteract the dawn phenomenon, the usual approach, guided by the provider, is to increase the patient's nighttime insulin dose. Specifically, the long-acting basal insulin, or the dose from an insulin pump overnight. More insulin is needed to cover that natural morning glucose surge.
Okay, more nighttime insulin for dawn. Now, the Somogyi effect. High morning sugar again, but a totally different reason.
Totally different, and this is where it gets tricky. The Somogyi effect is a rebound high. It actually starts with hypoglycemia overnight.
A low causes the high.
Yeah. Maybe the evening insulin dose was too high, or they skipped their bedtime snack. The blood sugar drops too low overnight, often while they're asleep. The body senses this danger, this low blood sugar, and panics. It releases a flood of those same counter-regulatory hormones, glucagon, epinephrine, cortisol, to push the blood sugar back up.
Ah, the body overreacts to the low.
Exactly. It overcompensates, and the result is rebound hyperglycemia in the morning. So the high sugar reading is actually a consequence of an earlier low.
Fascinating. Which group tends to experience Samoji more?
It's seen more often in people with type 1 diabetes, mainly because their glucose regulation is entirely dependent on external insulin, making them more prone to swings if doses aren't perfectly matched to needs.
Okay, so if Samoji starts with a low, how do you prevent it? What are the interventions?
Since it starts with a low, the prevention strategies are aimed at stopping that initial dip. Two main things. One, give a bedtime snack containing carbs and protein. This helps keep blood sugar stable overnight.
Snack before bed. Okay.
Two, if the overnight low is clearly caused by too much evening insulin, the provider might need to decrease the nighttime insulin dosage. Less insulin means less risk of dipping too low.
So just to be crystal clear for everyone listening, dawn phenomenon needs more nighttime insulin. Samoji effect might need less nighttime insulin plus a snack. Completely opposite.
Precisely, which is why figuring out which one is happening is so critical.
How do nurses figure that out? If a patient just reports high morning sugars, how do you differentiate?
The key is checking blood sugar levels during the night. You'd instruct the patient, or check yourself if they're inpatient, around 2 or 3 a.m. for several nights.
Middle of the night check. What are you looking for?
If the 2-3 a.m. blood sugar is low, and then it's high in the morning, that points strongly to Samoji effect, rebounding from a low.
Okay. Low at 3 a.m. equals likely Samoji.
Right. But if the 2-3 a.m. blood sugar is normal or even high, and then it's even higher in the morning, that suggests dawn phenomenon. The sugar's just steadily rising due to those morning hormones.
Normal or high at 3 a.m. Oatly Tundley.
Exactly. That middle-of-the-night reading is the detective work needed to guide the right treatment, adjusting insulin up or down, or adding that snack.
That's a fantastic clinical pearl. Okay, we've hit the meds and the blood sugar swings hard. Let's shift to patient empowerment. Self-management education is huge. Let's start with diabetic foot care. Why is this so incredibly important?
Foot care is absolutely crucial, non-negotiable for people with diabetes. They're at high risk for two main problems: neuropathy, which is nerve damage, and peripheral vascular disease, PVD, poor circulation.
Nerve damage and poor circulation, how does that affect the feet?
Neuropathy means they might lose feeling in their feet. They could step on something sharp, get a blister from their shoe, and not even feel it. PVD means if they do get a cut or sore, the reduced blood flow makes it incredibly hard to heal. Infections can set in easily and spread fast.
Wow, so they can get injured without knowing and then can't heal well. That sounds like a recipe for disaster.
It is. It leads to chronic foot ulcers, bone infections, and tragically, it's a leading cause of lower limb amputations. Meticulous daily foot care is all about preventing those devastating outcomes.
Okay, prevention is key. What are the absolute must-do instructions for daily foot care? What should patients do?
Several key things. First, inspect feet daily. Look everywhere, top, bottom, between toes, heels. Use a mirror if needed. Look for cuts, blisters, redness, swelling, anything unusual.
Daily inspection. What else?
Wash feet daily with mild soap and lukewarm water, not hot, and dry thoroughly, especially between the toes.
Dry between the toes. Got it.
Moisturize daily to prevent cracking, but don't put lotion between the toes, as that can encourage fungus.
Okay.
Cut toenails straight across, carefully. Prevents ingrown nails. If they have trouble seeing or reaching or have thick nails, they need a podiatrist to do it.
Podiatry referral sometimes needed. Anything else for the do list?
Always wear well-fitting shoes and socks. Never go barefoot. Shoes protect from injury. Diabetic shoes offer extra protection. Rotate shoes daily to avoid pressure spots.
Okay, inspect. Wash, dry, moisturize, not between toes, cut nails straight, wear shoes. Now, what about the don'ts? What should they absolutely avoid?
Big one. Do not soak feet daily. Prolonged soaking dries the skin, makes it prone to injury, and can worsen fungal issues. Gentle washing is enough.
No daily soaking. What else?
We said never walk barefoot, even indoors. Too easy to get cuts or burns. Don't try to remove calluses or corns yourself with sharp objects or harsh chemicals. See a podiatrist. And don't use heating pads or hot water bottles on feet. Neuropathy means they might not feel a burn.
Got it. No soaking, no barefoot, no self-surgery on calluses, no heating pads. Okay, moving on to exercise. What's the single most vital safety tip for someone with diabetes who exercises?
The absolute most important thing is to always carry a source of fast-acting carbohydrate with them when they exercise.
A snack for lows. Why is that so critical?
Because exercise uses up glucose. It naturally lowers blood sugar. For someone on insulin or certain oral meds, this can easily lead to hypoglycemia, either during or sometimes hours after exercise. Having glucose tablets, juice, or hard candy readily available is their safety net if they feel symptoms or their sugar drops.
Essential safety net. Okay. Last big education piece, sick days. These can be really dangerous, right? Why?
Sick days are incredibly risky. When the body is sick with a cold, flu, infection, any kind of stress, it releases stress hormones.
Like cortisol.
Exactly. Cortisol, epinephrine. These hormones directly raise blood glucose by stimulating the liver to produce more sugar, and they can also increase insulin resistance. So even if the person feels awful and isn't eating, their blood sugar can soar.
So being sick itself drives blood sugar up. Wow. What are the essential sick day rules nurses must teach to prevent emergencies like DKA or HHS?
Okay, non-negotiable sick day rules.
Ugh.
First, check blood glucose frequently, every 3 to 4 hours, around the clock if needed.
Frequent checks. Got it.
Second, stay hydrated. Drink plenty of fluids, especially sugar-free ones if blood sugar is high. Dehydration makes everything worse. Aim for fluids every hour.
Fluids. What else?
Third, check urine for ketones. If blood glucose is 240 milli-GDL or higher, ketones are that warning sign for DKA. If they're present, especially moderate or large, they need to contact their provider.
Check ketones if sugar is 240 or more. And what's the absolute never rule for sick days? The one thing they must not do.
Never stop taking insulin. Even if they're vomiting, even if they can't eat, their body still needs insulin, maybe even more insulin, to prevent DKA caused by the stress hormones. Stopping insulin, especially for type 1, is incredibly dangerous.
I've never stopped insulin. Got it. That's huge. What about fluid choices? Sugar-free versus sugary?
Depends on the blood sugar. If blood sugar is high, like 300, stick to sugar-free fluids, water, broth, diet drinks. Don't add more sugar.
Makes sense.
But if their blood sugar is low, like 55, during their illness, then yes, they need a sugary drink or food juice, regular soda, regular Jell-O, to bring it up quickly, following the rule of 15 if they can.
Tailor fluids to the current blood sugar.
Okay.
And teach them when to call the doctor.
Absolutely. Call if they can't keep fluids down, if they have persistent vomiting or diarrhea, moderate large ketones, blood sugars staying very high despite extra insulin, or if they just feel really unwell or unsure. These sick day rules are a survival guide.
Wow. We have covered an enormous amount of ground today. This has been a true deep dive. We went through the core differences between type 1 and type 2, those crucial diagnostic labs like A1C and FBG, the key medication principles holding metformin, insulin types, mixing rules, site rotation.
The rule of 15, glucagon.
Right, managing lows, decoding dawn versus Samoji, and then all that vital patient education, foot care, exercise safety, and those critical sick day rules.
And all of this, it's not just abstract knowledge for you, the nursing student listening. It's truly the foundation of providing safe, effective, and compassionate care.
Yeah.
Understanding the why behind these guidelines, being able to connect the dots between the physiology, the labs, the symptoms, the treatments, that's what allows you to anticipate problems, intervene effectively, and empower your patients. It directly impacts their health and well-being.
Absolutely. It's about building that competence and confidence. So as you take all this in, maybe mull this over. We know diabetes management is complex, influenced by so many things: genetics, environment, access to care, technology.
Constantly evolving.
So thinking ahead, how can nurses like you leverage new tools, maybe continuous glucose monitors, telehealth, apps, or even better utilize community resources to help patients manage their diabetes even more effectively in their daily lives, beyond just what happens in the clinic or hospital?
That's a great question. How do we extend that empowerment and support?
Exactly. How does this foundational knowledge prepare you, not just for today's practice, but for a career of adapting, learning, and finding innovative ways to support people living with diabetes? Something to think about.